So we're going to go on, I guess, straight on to the next talk, which is going to be me. I'm going to try and just cover a little bit of background information and set up some questions so that Dr. Wong can talk about what we've been working on in the lab, which is working towards immunotherapies. And one of the areas that people have been talking about forever are cancer vaccines and what is their potential for mesothelioma. Unfortunately, although for the most part vaccines have eliminated many diseases from being significant problems in the world, working with cancer is a little different. But it still has some potential, and I think that in particular for surgeons it actually might have a significant potential. So I'm going to talk about some basic stuff about that. So again, I have my disclosure, a general outline for what I'm going to talk about. I'm going to talk about a review of vaccine properties and some general information from vaccines that have been used in other diseases, particularly lung cancer, about whether they're being successful or not, and also the possible applications to mesothelioma and how it might be used. So the basic definition of a vaccine is it's a biological preparation that provides active, important is active acquired immunity to any particular disease. So it's not necessarily an infectious disease, it can be cancer as well. And there's different types potentially, and this is important because most of the vaccines that we are aware of, and like the flu vaccine and all that kind of stuff, are prophylactic vaccines. That is, that they're administered before you have disease. But often in cancer, obviously, people have the disease before you start giving them vaccines, and it's much harder to do that. So that's more of a therapeutic vaccine where it's administered after the disease is already present. And in most infectious diseases, that just doesn't work. So stretching that to cancer makes it even doubly hard. So the principal components of any vaccine is usually an antigen source. So you have to have something that you're going to react to. And you have to have something to help your body to react to it normally, which is an adjuvant. And there's a whole slew of adjuvants that have been used in a lot of different areas. So you can look at all kinds of different adjuvants, both in infectious diseases and cancer, and pick your poison, but they're all designed to stimulate the immune system with the antigen present. They all have specific side effects, and one of the things that hopefully is coming about more recently with listeria and other things, that there are modified adjuvants now that have fewer side effects that can be used to help equally stimulate the immune system but have fewer side effects at the same time. So classic vaccine-treated diseases, of course, are infectious diseases, and the World Health Organization has 25 preventable diseases that are all treated by vaccines. There's also the human papillomavirus, which is also an infection, but because you can treat the viral infection, you also can prevent some potentially sequelae, and this is something that not only occurs in cervical cancer, but when it gets in the airway, you can get squamous cell carcinomas of the airway, and if you can prevent it or treat it when it's already there with a vaccine, then it certainly goes a long way to preventing the subsequent malignancy. So again, what we're talking about is an active immunotherapy here, where you take a vaccine, you stimulate the patient's or the person's immune system. So the person's immune system is what's fighting the cancer, not a passively transferred molecule or cell. And the way vaccines generally work is, you've seen this kind of before in general, but you take a vaccine, you inject the antigen in the adjuvant, and antigen processing cells, either macrophages, dendritic cells, or whatever, pick up the antigen, they process it, and they present it to cytotoxic T cells, which is an MH1 restricted process in general, and it stimulates the cytotoxic T cells that would then rally around whatever substance you're trying to fight, and it would kill this thing. And also through an MHC2 class restricted area, you can stimulate helper cells, which can then have an impact on a variety of other cells, including plasma cells and other non-specific NK cytolytic activity. So all this stuff happens from just the vaccine. Now, one of the problems with using vaccines, or actually one of the benefits of using the vaccine, is partly what Dr. McCart just mentioned, is that this is some work from a long time ago, actually, back in the 70s and 80s, from Isaiah Fidler, who was MD Anderson, and Talmadge, who looked at a number of murine tumors, and they were able to clone a bunch of different clones of the same specific genetic tumor, but they had totally different properties in terms of chemotherapy sensitivity. So this is adriamycin, this is bleomycin, vincristin. You can see that the numbers here, which are the sensitivities to each agent, vary tremendously, even though the tumor is exactly the same. So these are two different tumors that are mirroring tumors. And so the problem is with any tumor is that there's heterogeneity. And one of the issues with giving vaccines, if you have a single antigen or epitope that you give a vaccine, it's going to fight cells that express that. But if there are cells that are present that don't express it, then you're not going to have a vaccine to kill those cells as well, unless there's an additional process. So one of the issues with getting vaccines is what's your antigen source and how useful is that antigen source. So the other thing about a vaccine is that once you stimulate, and this kind of came up earlier, once you stimulate the immune system, you can stimulate the immune system, and that's in a lot of ways the easy part. But one of the hardest part is to penetrate through the immunosuppressive environment of the tumor. So you can get a lot of active cells, you can be immune to it, and this happens with a lot of immunotherapy trials. You'll see that there are active evidence of immunity in the patient's blood, but when you get to the tumor, nothing happens. So what happens in the tumor, there's fibroblasts that secrete different factors that are stimulated by the tumor cells, as well as tumor-associated macrophages that also secrete things, and with somehow in an interaction which is not really totally understood between the tumor cells and the surrounding cells, including the fibroblasts and macrophages, an environment is set up so that the immune cells, once they penetrate in here, they really don't do anything. And so some of the things that we're trying to control is the actual immune components, and so that macrophages is kind of something that isn't too glamorous to study. A lot of people don't look at it too closely, but it is very important because the monocytes that can differentiate into macrophages can differentiate into two different lines, M1 and M2. And M2 also has M2A, B, and C. But in general, these are created by a different type of cytokines, and one type of macrophage can, in certain circumstances, can be an anti-tumor macrophage, and in other circumstances, it can actually be a pro-tumor macrophage that will support the growth of the tumors and suppress actually the cytolytic T cells. So controlling the environment and controlling which one of these things is occurring within the environment is an important factor in terms of making vaccines work. So the controls can become very complex. So a tumor macrophage or tissue macrophage can actually go different ways, but you can see the number of different factors that can influence which way it goes into which type of ultimate mature macrophage and what kind of consequences it might have in terms of tumor rejection or tolerance. So what we want to do is look at has any vaccines ever been really useful? In lung cancer, there have been a number of vaccine trials that have been looked at. And like I said, I mentioned this morning, if you look in cancers and you take cancers out of the body, put them in a petri dish, for the most part, most cancers don't grow well in petri dishes. So what happens is the tumor cells start to die, and lymphocytes, if you put them in IL-2 in particular, they start to multiply and they will kill the cancer cells. You take those lymphocytes out, they're very specific for that tumor oftentimes. And so you can do that with lung cancer, esophageal cancer, mesothelioma, as well as a number of other tumors, but these are just the thoracic ones. And they've all been documented to occur, so there are cytolytic T cells there. That's not the issue. And when you look at lung cancer, there have been a number of vaccines created for different antigens, including MAGE-A3. And again, goes back to what Dr. Ricart said, is that these antigens are usually present on a minority of tumor cells. In lung cancer, that's one of the biggest problems, that there's nothing that's really on a lung cancer cell line or a lung cancer tumor more than 50% of the time. So it's very hard to find an antigen where you're going to make a big dent in the tumor and survival of patients when you don't actually kill even half the tumor. So these are all trials that have been done. For the most part, there have been negative trials. So you can't really say that there's been a positive trial where a vaccine has worked and prolonged survival with lung cancer. But interesting, when you look at a lot of the trials, this is a meta-analysis that was done of a number of different non-small cell lung cancer vaccine trials. Again, the meta-analysis shows two different ways along the line, and this way to the right shows that there's a benefit to the vaccine, and to the left is that there isn't. So in general, data would suggest that there may be a very slight benefit to vaccine therapies, even though clinically, when you try to look for a survival benefit, you don't see it. But this would suggest, at least in 11 randomized controlled trials, that there may be a slight benefit to vaccine therapy. So that would be encouraging for us in mesothelioma, because at least we have another thoracic malignancy that might have some evidence that this could eventually work. So looking now at some more experimental evidence to see in animal models, whether and what the conditions are that vaccines work. So this is a BALB-C animal model of some mice with a mesothelioma tumor that's been transfected with a GAG antigen that's off from an HIV capsid protein. So that's the antigen that's being used to generate the vaccine against. And this is kind of the very early basic kind of model where you actually take these animals and you take and vaccinate them to this antigen that's on a PD-1, attached to a PD-1 molecule actually, and you vaccinate them first, and then you inject tumor to see if it's rejected. So theoretically, this is the easiest thing to do. This is like an infectious disease. You vaccinate first, you make them immune, and then you try to see if the animals will reject the tumor. And in fact, if you look at, this is the just controls that are here. The tumor, when it's injected, continues to grow, and the mice die pretty quickly here. But if you inject and actually vaccinate the animal to the specific antigen that's on the tumor cells, it's actually rejected, and the tumor shrinks down to a very, very small volume, and the mice survive. So this is kind of a little bit of evidence that vaccine therapies could work, but again, this is a prophylactic vaccine where it's injected before the animal actually gets tumor, although interestingly, if you think about it, mesothelioma is a disease that has a 40-year latency period, and if we actually actively look for people who are exposed to asbestos and we had an antigen, we could vaccinate those people, we could vaccinate them against the mesothelioma before they got it, which is kind of an intriguing thought, but one that needs a little bit more development first. So now you want to look at the kind of cell type that this is dependent on, because obviously the tumor is being killed by something, so the question is by what? So this is now a therapeutic model where the tumor is injected first, and then the animal is vaccinated, and you see what types of cells that you can get rid of and see which ones it's dependent on. So there's CD8 or cytotoxic lymphocytes, and CD4 are helper cells, and these antibodies are to each one. And so you individually or together, you can eliminate one or the other, and you can see which one of this effect is dependent on. So here, again, is the injection of the tumors grow, and then if you deplete the CD4 lymphocytes, nothing really happens. Nothing happens, it continues to grow, but if you deplete sorry, we got that backwards. If you deplete CD4 lymphocytes, the tumor is killed here by the CD8 lymphocytes that are left over, but if you deplete CD8s, then the CD4s are left over, and it continues to grow, and the mice continue to survive. So this whole process, which is true of almost any tumor basically, is dependent on CD8 cytolytic T cells, at least to a great degree. And this is the mice that have been imaged. This is, again, looking at the control mice here and here, and this is the injected with the antigen mice and vaccinating. You can see that here the tumors get bigger and bigger and bigger, and here the tumors get smaller and disappear. And this is actually a group where they re-challenged it after they've already had mice that had the tumors disappear. They re-challenged it again, and the tumors again disappear. So it's a long-lasting immune reaction. So this is kind of a typical animal model. And then there's we mentioned the passive vaccines, and so you can treat patients with passive immunotherapy, and this is kind of one way to do it, which is to have an animal injected with tumor, and then you inject cytoxan, which is something that's very common to use in these models because it somehow depletes T regulatory cells enough to allow the immunotherapy to work. Then you give the T cells. Now, in this particular experiment, they took splenocytes from an already vaccinated animal, and they transferred CD8 and CD4 lymphocytes separately to see if that could transfer the actual immunity for these tumors. And what they found is that when you again, these tumors grew pretty consistently and killed the animals pretty consistently, but if you transferred CD8 T cells from an immune animal into another animal, you didn't need to generate any active immunity. It actually killed the tumors just by transferring those cells. But if you transfer CD4 lymphocytes, nothing really happens. So you need the CD8 lymphocytes to kill the tumor. So this just basically is basic information about how this works in animals, and we've tried to reproduce this in humans, and it's been somewhat difficult. So the question is how to make this actually happen in human beings. So one of the questions is, at least as I have as a surgeon, is how can we put this together with surgery? How can it possibly work together? It didn't really work with the vaccinia virus, but we're hoping that somehow the immune system can work with surgery, because as Dr. Vader said, basically if we minimize the tumor, then the immune system theoretically in most circumstances can work better on smaller amounts of tumor, we think anyway. So this is a different kind of model where you actually inject the tumor, which is an AB1 tumor, a mesothelioma tumor, and then you prime them with the vaccination, and then later operate on them about 8 days after you prime them, and you boost it a week later, then you operate on the next day, and then you follow them for survival. And so you kind of cytoreduce them, I guess what you would say, and see how they do. And so it's a little bit complicated to see this, and it doesn't work quite as cleanly, but these are the control animals where they're not cytoreduced, they're just giving, and they're given no active vaccine. They just die usually within 3 weeks. If you give them a vaccine, they live longer. You do surgery, they live longer, both about the same amount. But if you give both the surgery and the vaccine before surgery, then they actually do the best. So, whether this is because the vaccine can induce a little bit of systemic immunity, and then by doing the surgery, you can adjust the tumor microenvironment so that it actually is more receptive to the immunity and allows tumor-infiltrating lymphocytes to actually kill the tumor cells. That's one intriguing interpretation, but it seems like there is some role potentially for having surgery working together with vaccines that are given before surgery in order to facilitate tumor reduction. So this is another one of the depletion experiments, basically, and a number of the surgery was done the same way with surgery of vaccine before. If you deplete the CD4 cells, nothing really happens. The animals still survive pretty long term. If you deplete the CD8, they don't survive very long. So again, this is a CD8 dependent mechanism. So this is another kind of interesting thing I just decided to throw in. So you can think of a lot of different targets, and this is a Valovax, which is a vaccine actually these are treated animals with Lewis lung carcinoma and C57 black 6 mouse model, and what they do is they allow the subcutaneous model to grow, and then they've actually vaccinated the mice against placental endothelial cells. So for some reason, the placental endothelial cells share antigens with tumor endothelial cells versus normal endothelial cells. So the endothelial cells are actually different. So what this does, it actually vaccinates the animals to the endothelial cells, specifically in tumors, and then when you react to that, which is it's a vascular thing, so you should have access pretty easily to that. When you react to it, you basically clot off the blood vessels and the tumor dies. So this shows that when you do that, you vaccinate the tumor actually grows very little and nowhere close to the control animal. So that's kind of an interesting use of a vaccine, and that maybe in the future when we kind of figure out more interesting things like that in terms of placental antigens and things that they may not normally see, it might be something we can use more often. So why not combine surgery with active immunotherapy, and it's vaccines and other things, and I think that's kind of what we're interested in doing anyway. So the advantages of surgery with mesothelioma vaccines might be, like we talked about, is that surgical patients, first of all, are healthier. They're not patients with metastatic disease. People, it's always something that people say, that people with metastatic disease, advanced cancer, have immunosuppression, so they may not respond to these things as well. So that's certainly a possibility. Patients can be immunized preoperatively, and it's by itself is neither a big thing or not, but when you actually look at it, if you can immunize somebody preoperatively and then you can take out their tumor, you can assess the response in the tumor that you're taking out. So it gives you a lot of information potentially to figure out what the response is and what to do afterwards. And also, because of this, I think this is a really big thing that surgeons have the capability of doing. We can modify the tumor microenvironment in this disease, mesothelioma. When you operate on it, you expose hopefully you expose every part where the tumor is, and so you have the entire microenvironment exposed for potential modification. And so you can, during the surgery particularly, you don't necessarily need to put in chemotherapy, but we can put in immunotherapy types of materials, even PD-1 inhibitors, things that Dr. Wader was talking about, and something attached to a fibrin molecule that will stay there, and could be an immune adjuvant instead of just a plain cytotoxic molecule. So, and then following surgery, like we think, minimal disease is probably more effectively addressed by immunotherapy. At least it won't grow too fast so that it gets out of control before immunotherapy has a chance to generate an immune response. It might be actually the ideal model to test that. So what kind of protocols can we imagine that we're kind of thinking about working on? One is to take a patient who's been diagnosed with mesothelioma and then do a cryoablation of part of the tumor preoperatively. So this cryoablation I haven't talked about, but as it turns out, cryoablation is a very effective mechanism of killing tumor, but it's also the same mechanism that many people use to prepare tumor antigens. So if you have a tumor, if you freeze thaw the tumor multiple times, you have a very reliable tumor antigen prep. And it's not any particular antigen. You can produce a mixture of antigens which would be more effective than just a single antigen. So in a lot of ways, we're doing this clinically already, so we can utilize what we're doing clinically and potentially preoperatively just cryoablate a bigger area of tumor and inject an adjuvant right afterwards. And then shortly after that, you can do the lung-sparing surgery, take out the residual tumor. You can assess the area that you've marked and treat it as a vaccine for what kind of infiltrates and reaction in order to gauge what the future might bring. And then you can do intraoperative treatments by adjusting the microenvironment. I think Dr. Wong is going to talk a little bit about what some of the possibilities are that we're thinking about to do intraoperatively rather than just cytotoxic chemotherapy. And you can follow them post-op, and even right after surgery, start them on a PD-1 inhibitor or some other adjuvant that will actually keep the immune system running instead of letting it shut down like it often does after surgery. So potentially this altogether could be a much more effective method of controlling the disease than the other types of therapies that are being tried over and over again. So in general, I think that cancer vaccines, although they haven't been too promising or at least most people aren't too excited about them, I think they actually hold a pretty promising avenue for treatment, and I think it's something worth looking into more. It'll be likely need to be with other therapy because the tumor microenvironment, no matter what you do, no matter how much you stimulate the immune system, you need to somehow affect the microenvironment, and whether that be actually radiation preoperatively, and now that you've actually knocked out T regulatory cells in that area so that the immune system is different in that tumor microenvironment, or whether it's using some other method, you can certainly imagine doing that relatively easily. And then the vaccines can be, at this point, one of the biggest things I think that's really promising is you can now boost the effect by administering a downstream PD-1 inhibitor or CTLA-4 antibody inhibitor, so that these checkpoint inhibitors will improve the actual response and keep it going rather than have it run out. So I think, to summarize, that surgery is, I think, an intriguing part of immunotherapy, so I think that that's one of the things that we're looking for to investigate in the future. And I think that's it for my talk. I'll take any questions.